Hey, good morning and welcome to EuroNurse. We meet every Saturday at 9 a.m. Central Time. If you're watching this on YouTube, great. Be sure to hit that like button and that subscribe button. And as of last week, we started to be over Facebook too. So there's the like, share, and follow on Facebook that you can utilize. Welcome to all of our viewers. If this is your first time checking us out on EuroNurse, be sure to check out our website at euronurse.com, where you can find out more about us and how you can become part of the audience and how you can share in all this. It's also the best place to see all of our past videos, and we have a bunch of them up there. For a matter of fact, we've got 32 episodes. This will be episode 33 for us, so we're really coming along with lots of episodes. I'd like to thank our supporters that have helped sponsor this program. If you're interested in sponsoring the program, hit that sponsor info button on the screen there on the website, and you'll be able to get more information. Now, since we are streaming over YouTube, Facebook, and StreamYard, the same way to communicate through all medias. So you can just use the comment box and send any of your questions to us. We always start off the show with some general questions. And once we get through our general questions, then we go into our main show. Today, we got a great one for you. This week, Dr. Ike Oguejiofor is going to be joining us. He's going to be talking about robotic cystectomy. So we're looking forward to that. And so let's go ahead and meet our panelists right now that we have on with us today. I'm going to bring them all into view here. For those of you that are new to the show, my name is Vic Sinise. I'm the host of the show, and I've been in urology for 30 plus years. I quit counting after 30, but it's been a long time and really an enjoyable career. This is my way of giving back. Going in order, Andrea, why don't you go ahead and give your introduction?
Hi, my name's Andrea Strong. I'm a nurse practitioner. I work in Wisconsin. I've been working in urology as a nurse or nurse practitioner since 2010. I've done inpatient, outpatient. I'm also certified as a urology registered nurse. Thanks.
Great. And Dr. Ike, why don't you go ahead and let us know what you do?
Yeah, I'm Dr. Ike Oguejiofor. I'm one of the partners at Associated Urological Specialist in Chicago Ridge, Oaklawn. I specialize in robotic surgery, endourology, and stone disease, and also oncology.
All right, great. Great to have you with us today. So we're going to go into our favorite stories section. And I'm going to kick it off. I don't think we have a lot of us with favorite stories, but I've got one I think that really fits the bill for today. So my favorite story is basically what I call a good way to get patients to relax for a procedure. And that's just what we call distraction therapy. So one of the things I always do is, and most of what I'm involved in right now is prostate biopsies. So getting patients ready for it, assisting with it, and the whole procedure, I'm there. So I always start by having some music playing. Music's a great distraction. And most of the patients now coming in are kind of my age, so we pick the same songs. So this what I've got playing, they'll always start talking about, oh, I know that band, and I remember this. It gets us chit-chatting. I always look and see what they're wearing, because if they have logo wear on, like the Bears, the Bulls, the Cubs, who supports the Cubs? Anyway, if you have logo wear on, we'll talk about teams and stuff like that. And then this is what has to do with Dr. Ike, because he'll come into the room ready to start the procedure. Patients, like I said, they're always nervous, and they can't see what's going on because they're not facing where they can see. And he and I will always go into some kind of crazy banter, whether we're talking about technology, politics, just the weather, what's economics, whatever we decide to talk about, we'll just get chatting at it. And some patients will join in, most will just kind of listening. And the thing is, that's where it's key. They start to listen and they pay attention to us and not what we're doing. And I'll tell you, it's surprising how many patients will get up and say, wow, I was so nervous and this really was nothing. And I've had a few of them actually call me out on it, and they'll say, you know what? I know exactly what you guys were doing. So we got to keep doing it because it works. It's really a good way to get patients into a better mood. Any questions from the audience, feel free to submit those into the comments. We'll grab any questions that you have. If not, we're going to just move along into our show. I don't see any, so I'm going to go ahead and bring you up on the screen here, Ike, so you can switch over to your...
Okay.
slideshow.
So today we're going to talk about robot-assisted or robot-assisted laparoscopic radical cystectomy. Basically, I know this is a medical audience, but a cystectomy involves removal of the bladder and also all the other organs that are around the bladder, including the lymph nodes. And after you remove the bladder and the lymph nodes, you also have to do what is called a urinary diversion, which is find a way to reconnect the urine that is made from the kidney down the ureters will still have to come out in some way or fashion. And who is a candidate for this? Candidate is somebody who is being treated for bladder cancer, and usually the indication is for patients who have muscle invasive bladder cancer. And as you all know, bladder cancer goes from non-muscle invasive to metastatic disease, but usually a cystectomy is reserved for patients who you are trying to basically get local control of the disease and by removing the bladder. Um, so those patients who you deem adequate enough to undergo cystectomy are the ones I usually, will offer the procedure to. And now the standard of care is to do neoadjuvant chemo before you actually proceed with doing cystectomy. So radical cystectomy treatment of choice when it's non-metastatic muscle invasive disease. So the cancer hasn't spread beyond the bladder anywhere you can see. And after that, give chemotherapy. After chemotherapy, then talk about removing the bladder. You can still do cystectomy in some instances. For example, when a patient has a very large tumor burden, but it's you can't prove that is muscle invasive, or in some cases, patients who have locally advanced disease, and in some patients who actually respond, they may have metastatic disease, but after they get chemotherapy, they respond well, and you want to consolidate treatment. You can still do cystectomy in those cases. The ways to do cystectomy, you could do it open, you could do laparoscopic, or you can do it robot assisted. I would say for the last 13 years now, 14 years, I have done them strictly robotically. And in doing it robotically, what you're doing is basically putting in laparoscopic ports and then using the Da Vinci robot system. A lot of my talk is basically a bunch of pictures, and Vic or Andrea, you guys can pause at any time, or anybody else can ask a question, and I can explain. It's easier to talk about it by talking about the using pictures. Like you can see here, the camera port is usually at the 12 o'clock position, and then there are other smaller 8-port, which are the red circle, the open circles. And then a 5-millimeter port is for an assistant, as well as a 12-millimeter port, and that's for an assistant to bring in instruments. And you would actually see when I show you pictures of how these ports come into use. So to understand the Da Vinci system, there's the platform, there's the surgical console where there's the console where the surgeon sits on. There's the patient cart, and then the vision cart. So the way this works is the patient cart is what basically is connected to the ports that you saw on the previous slide, and then the surgeon sits on the console to control the patient cart. All that information is managed and controlled using the vision cart. So it's a system that removes the surgeon from the bedside, and in terms of doing surgery, you're basically doing the surgery sitting down here and looking through the surgeon console, and then operating the patient cart to do surgery. And kind of what it looks like is here's the surgeon sitting here, he's with the fingers in the surgeon console and moving the instruments while he looks through the IP view of the surgeon console. So how is robotic surgery different from laparoscopic surgery? The biggest difference is the degrees of motion that you can get with the instrument. In a standard laparoscopy instrument, just, what I tell my residents is I think of it as you're operating with chopsticks. You can go up, down, in and out, and and a little bit of sideways. That's pretty much what you can do with laparoscopic instrument, as you can see from the slide on the left side. Now, with the robotic instrument, you have a lot more degrees of freedom, and you can go in, out, rotate the shaft, go pitch, yaw, both externally and internally, and you could do that at the wrist. So this basically, what the robot does is that it gives the surgeon back his hand. It's as if the hand is back inside of the patient, and you're using it to do surgery, because you can almost move it in any direction you want. Now, these surgical atlases, this is where I got a lot of the pictures that I'll be showing you guys to kind of describe the procedure. I figured that using illustrations is better than just trying to explain it. So for reference and for credit, this is the area where the atlas where I got my pictures from. So the first stage of the procedure usually is to identify the ureter when you start. And the ureter, as you can see on the first image on the left side, we find it where it crosses the pelvic brim, and this will be here, the common iliac artery heading towards the external iliac artery, and then the robotic instruments as well as the sucker is used. You identify the artery, not the artery, the ureter, and then place a clip at the tip of the ureter. Do that on both sides, and then afterwards, the next step is to basically mobilize the posterior base of the bladder. And by doing this, it's called doing your posterior dissection. So you're basically peeling off the bladder from the rectum. And in this picture will be in the man, because obviously there is no picture of the ovaries or the uterus or any other female organs here. So once you complete this dissection, and I do this way too. After getting the ureters on both sides, you do the posterior dissection to try to release the posterior attachments of the rectum from the bottom part of the bladder, the seminal vesicles, as well as the prostate, and you go as anterior as not anterior, but as distal as you can. The one thing about robotic surgery that is very, very different from open surgery is that when we do this open, we do this practically blind. We just basically put our hands in there. We get that window, we put our hands in there, and we just kind of work it all the way up and hopefully get to the right place. But with robotic surgery, everything is done on the vision. You see every single thing that you're doing. You can't do anything without seeing it. Then after that's done, with the bladder still attached, the next goal is basically to do the lateral dissection and open up the pedicles, and also start the lymph node dissection. So in this case, it is being done on the right side, and then later on the left side. This will be the psoas muscle. This will be the iliac vessels, and the lymph nodes that are taken basically start from the genitofemoral nerve. This will be the genitofemoral nerve running on top of the psoas muscle, heading towards the inguinal canal, and you will take all the lymph node packet that is surrounding these vessels all the way up to the common iliac is standard. I usually go all the way up to the aortic bifurcation, and you will go also down towards the obturator vessels. So everybody kind of does this slightly different. I usually will remove the lymph nodes. I would actually free up the bladder first, and then remove the entire bladder before I start doing lymph nodes. In this series, what they described is kind of like how I was trained too, which is to do the lymph nodes first and afterwards then remove the bladder. So in this scenario, they basically just continuing the lymph node dissection, kind of showing. So this would be the the external iliac artery. This will be where the common iliac is. This is the external iliac vein on the left side, and all this lymph node. So the lymph node packets, I always get the question from residents like, oh, how do you know which one is the lymph node? Basically, what you're taking is all the fatty tissue that is all around those vessels, and you're skeletonizing everything from beginning to end. So that when you're done, what you have is a picture that looks like this, where, initially, if you remember when we started, these vessels were not looking like this. Now they're looking basically all exposed and all shiny because every single lymphatic tissue around them has been released. So this will be the common iliac artery here. This is the internal iliac artery. This will be external iliac artery. This will be the external iliac vein. And then once the lymph node dissection is completed, then you start taking the pedicles of the bladder and start releasing the bladder. So that's, the pedicles are being taken here, and then the dissection is now carried anteriorly to drop the bladder on this side. And once you've taken that, then the dorsal venous complex is this here, and this can bleed. Trust me. That's the reason why this is oversewn. Usually it is cut blind, not blind, but it's cut without electricity. Sometimes I ligate it before I cut it. Some people just cut it and then, ligate it afterwards. But pneumoperitoneum does wonders, because when you cut this dorsal venous complex, what you will find is that you just turn up pneumo to like 20. And even though this big blood vessel is wide open, it will not bleed, which, kind of goes to the advantages of robotic surgery. One of the biggest advantages of robotic surgery is that the amount of fluid shift that we used to see on patients that we did cystectomies on, we didn't see when you do robotic surgery, because the patient is not open, and you're not having insensible fluid loss into the environment. We don't see those fluid shifts, and the amount of bleeding that we normally get is also something that we don't get. I mean, open this surgery people can lose anywhere from 500 cc's to sometimes a liter, but robotic, in my opinion, I call it like you barely lose blood. The only thing that you actually see is a lot of lymphatic drainage. So this is continuing with the complete dissection. And so to complete the dissection in the male, in this stage, you've done all the lymph node dissection. You've taken the dorsal venous complex, and then you're clipping the last of the pedicles. And then the only thing left is the urethra. Now, remember, the bladder has urine in it, and you do not want the contents of the bladder to spill out into the surgical field. So before you cut the urethra, you actually ligate the urethra with here they use the wet clip. I usually will tie it off. Actually, I do both. I'll tie it off and also put a wet clip before I cut it open. So at this point, the cystectomy is done, meaning the removal of the bladder and the lymph nodes are done. Now, in the female, it's different, because in a female, as you can tell from anatomy days, the anterior vaginal wall is also part of the base of the bladder. So in a female, what we do is that we put a sponge stick or some type of instrument in the vaginal canal to basically distend the vaginal canal. And when we do the posterior dissection in this scenario, we'll be incising the lateral wall of the vagina, and basically taking. So when we do a cystectomy in a female, we take both the ovaries and the uterus, and uterus cervix and anterior wall of the vagina is also taken out. What will be called anterior exenteration, basically. So after you're done, you will then have a hole where now the posterior vaginal wall is used to flip over and basically close. So this here will be the sponge stick that is in the vaginal canal, and then you would kind of free up the posterior vaginal wall, some portions of it, and use it to close the defect. For me, thus far, I haven't done vaginal sparing cystectomy because it's very difficult, and then two is that you have to kind of do it on the right patient. Patients that don't have any cancer close to their bladder neck. If you're trying to spare the urethra and use it, for a neobladder or something like that. So it's in my experience, I've basically every cystectomy in a female that I've done, I usually will remove the anterior vaginal wall. And the downside of that is that it does shorten the vagina basically after the procedure, because you've taken out at least a good 2/3 of the vagina. So after you're done, it will be a very short vaginal canal. Now, moving on to the urinary diversion, this is I usually do an ileoconduit. I've done some neobladders, but that ileoconduit is easy to describe. A neobladder has more steps and is more complicated, but an ileoconduit is simpler. The thing with an ileoconduit is that you are basically taking a small segment of bile of a small intestine, which is from the terminal ileum. We measure out. So this will be on the right side of the screen here, it will be the ileocecal valve. Okay, from the ileocecal valve, we measure out about 15 centimeters, and then from there is where we start measuring our bile to use for the ileoconduit segment. So as you can tell, working with bile is challenging, but because of the articulation of the robotic instruments, we're able to do that. And the reason you preserve this portion of the ileum is because this is important for vitamin B12 absorption, and it's kind of necessary for digestion too. So once you mark out that 15 to 20 centimeters, I usually start around 15 to 20, and then from there you measure backwards and then measure what length of conduit that you want. I usually use about 10 centimeters of bile. You tack up the terminal. What will be your let me call this what will end up being your conduit, the stoma. You tack up that end to the skin, and then the other end your robotic arm brings up. The other thing that's important is that your ureter from the left side is usually we cross it over under the sigmoid to the right side, because we have to anastomose both ureters to the bowel segment. So in this picture, so remember we tacked it up to the body wall, and then the other robotic arm is holding the other portion of the valve. Then the mesentery is opened, and the goal here is to preserve the blood supply that goes to this segment of bowel. You want to preserve it as much as possible. So we make an incision running parallel to the blood supply, heading towards the root of the mesentery on both sides, and then afterwards divide the bowel as they did here, and then now you have your isolated loop of bowel that you're going to use for the ileoconduit. Then the two cut ends are basically you tag them like this so you don't forget, and then flush the conduit. So previously, when I did open surgery, we would have patients do bowel prep, where they would take Go Lightly and basically show up to the hospital pooping clear. Now I don't do that anymore. What I tell patients to do is 2 to 3 days before surgery, clear liquid diet, and they stay on liquids. And what I've found during surgery is that when we do irrigate the loop of intestine that we use, if they actually did stay with the liquid diet, we actually don't have a lot of fecal matter here. We actually can irrigate this with a Foley catheter and a suction, and it clears up very quickly. Now, Where I differ in this picture is that I actually will reanastomose this bowel first before I start doing the conduit surgery. So, because the last thing you want is to finish surgery, do the ileoconduit, and then forget to hook the bowel continuity, reestablish continuity between the bowel. So, but for illustration purposes, we follow the picture. So after you irrigate the bowel clear, we anastomose the ureter. So this is the right ureter, gets anastomosed to the butt end of the conduit, and then the left ureter is also done on the other side. And I usually do this in a running watertight fashion. And after that's done, you then put a stent in, and that stent is actually brought into by the patient assistant from the patient assistant port, and then threaded all the way up into the kidney, and then brought out through the skin. So you do this on this here. They did it on the right side, and then afterwards you do the same thing on the left side. So this is completion of the right anastomosis. After it's done, then the left side will be done, and then here we start working on re-establishing the flow of the bowel by reconnecting the proximal segment to the distal segment. And again, as you can see, all these are done robotically with robotic instruments. And what I call this is making a very big donut. You kind of make a big donut between the two. You make a small, so in this picture, you make a small opening in both ends of the bowel. Remember, we put them together here. And then you make a small opening on the anti-mesenteric portion, and then put a bowel stapler in between the two, and then kind of staple them shut, hence connecting this tubular structure to this tubular structure. And then afterwards, the top opening here, you put another stapler here to kind of close it off. And now when you're done, you have the bowel reconnected, flowing from this direction to this direction. And then after you're done, now you have your ileoconduit completed with its mesentery, and the stents are in, and then you basically thread this through a hole from one of the, usually it's the port, one of the ports that we use for surgery gets converted to our ostomy site, and then you bring it out to the skin. So that's my presentation. Any questions?
So I'm just going to bring us all back on screen here. I do have some questions coming in from the audience, and now is the time that if you have a question, feel free to submit those. Let's go ahead and bring up this first one. Katie Bortel asked, who is a candidate for robotic cystectomy, and have you ever had to change to open procedures?
So a candidate for robotic cystectomy, in my book, is somebody who is healthy, has a good performance status, can tolerate surgery, hopefully not medically, somebody whose heart and lungs can tolerate being in Trendelenburg positions for a very long time, and also somebody who does not have any major bowel issues.
Okay. Have you ever had to convert from robotic to open procedure?
No.
It's fascinating just to hear the talk on this, because I know what it's about, but I've never gone through the whole procedure like you were able to kind of dissect it. And it's pretty impressive that you can do all that with a robot.
So the biggest advantage of the robot is that, it gives you back, like your hands, in the sense that the things you could do open, you can now do it like, you kind of think of it like you're operating under the hood, but you still are able to kind of, do your feet, whatever, when you put your fingers in that, in the surgeon console, whatever you want to do, if you want to do this, you would do this with the instrument. Yeah. So it's very, very intuitive, and it just gives you back, what you would have done open. Now there is a learning curve where, you have to kind of rewire your brain to, because there's no tactile feel. Like you don't actually, everything is, you kind of feel it in your brain. That's what I explained to residents. It's more like you're looking at it and you think, if I touch that, I will know I'm holding it. No, it's your eyes is the only thing that tells you you're holding something.
Yeah, early on when I was before robotic was just kind of in its infancy, I was at the AUA and they had a excuse me, a setup where you could go over there and play with the robot and tie stitches and things like that.
Yeah.
And so I was able to go and sit down and play with the robot for a while. And it is kind of interesting, as you say, there's no tactile, but the manipulations, I mean, yeah, it's a learning curve, but you can start getting to the point where you could actually tie a suture with the robot hands pretty quickly. It's kind of an amazing process. So I have a question coming in here. What is the average time of robotic versus traditional surgery?
So that depends on surgeon experience to start with. For somebody who does a lot of robotic surgery, they average actually for a cystectomy, I would say roughly about 6 to 8 hours, depending on how what takes the most time in cystectomy is the lymph node dissection and doing the bowel reconstruction.
Mhm.
Because as you can tell, you are trying to, if you've ever worked with intestine, like it doesn't stay anywhere. It just wants to swish around. So you have to kind of hold it. Yeah, the first few times you work with it is very difficult, and that would extend your surgical time. But once you've done it a couple of times and get a hang of it, I would say um, about 6 hours. Now open, it would be about 4 to 6. Now the thing with open is that most urologists don't do cystectomy solo, meaning like they do it with another full-fledged board certified urologist. With robotic surgery, I'm doing this with with an assistant, like basically a surgical assistant or a scrub tech, or that's who's in the room. And I have the fortune of having residents, but only one as you can see in the robotic surgery, only one person can work at a time. So you don't actually get that expediency of doing things faster, because there's only camera can only look in one direction at one time. When you're doing open surgery, you got two surgeons and they work in tandem, and it's a lot faster. I'll tell you that.
Yeah, it's still a long operation. When I
Yep.
first joined the group, in order to know what the surgeries were, they felt it was important that I scrubbed in on all the cases that they did, their major
Yeah.
cases. And most of them were kind of fun to sit through. Radical cystectomy was not a fun thing to be there for. I was like,
Yeah.
this is never going to end. It just,
Yeah.
as you say, the bowel part was crazy. It's
Yeah.
just how long it took.
That was the reason I chose to just use illustrations for the talk, is because I think for a lot of nurses, we hear the term, but we don't actually know what actually goes into seeing it. And when you see it, is a procedure that has a lot of steps. Like when I say steps, I mean a lot. I know I made a joke about like that reconnecting the bowel. You will not believe how after about 7 hours of operation, your brain is fatigued, and you forget one simple step, and that's a complication right there. So
Yeah.
it's a very, very long surgery and very difficult surgery.
Yeah.
Now, you had mentioned in the female side, the vagina is compromised or made
Yes.
short. And have patients been able to get back to normal sexual function?
Well, my experience, in my series of patients, those ladies were at that point not sexually active anymore,
Mhm.
and even when I brought up the topic, they were not really interested. Now, in a younger patient, who, let's say somebody who's 55 and sexually active, and they want to retain the ability to have sex, what I would do is I would send them to my colleagues at the university who can do the vaginal sparing, because the big thing with vaginal sparing is that it has to be the tumor has to be in the right place, is one, meaning like somewhere away from the urethra, the bladder neck, the base of the bladder, ideally like on the lateral wall, away from all these things that you're trying to spare, so that you don't compromise oncologic outcome. If you go in to spare the vagina, but then you end up leaving cancer behind, that's not good. So I I cancel all my patients. I cancel them to say, hey, listen, when I do this, I take everything out. Now, in men, when we do it, because we do nerve sparing prostatectomies, when we do robotic surgery, we also do nerve sparing robotic cystoprostatectomy. We actually do the same nerve sparing that we do in men for prostates. So you can still have men that would still retain erection, if that's something that's very important to them. But again, it all depends. And the one advantage of robotic, especially in bulky disease, is that you can sometimes, when we did open, we feel, so we can feel like where it's hard and things like that, and we decide, oh, we're not gonna we have to be kind of wide in this area. With robot, when you're looking, you can actually see areas that don't look right, and the way they feel too. I mean, even though you don't have that tactile feel, when you move tissue, there's a way that tissue will move and it's moving normally, and there's a way it will move and like this thing is not moving, it's stuck. And in that scenario, you kind of know like they have something that is way worse, and trying to do nerve sparing or any of all that stuff is probably not worth it. And you take everything.
Yeah.
Thank you for that presentation. That was really great to see all the pictures. I have a question actually about surgeon health. So it sounds like these surgeries are pretty long, 6 to 8 hours. I'm looking at the console that you're sitting at.
Yeah.
And I'm thinking about ergonomics.
Yeah.
Can you speak to that? How is there an opportunity to adjust the equipment to fit?
There is. You can adjust the visual part, so the head part, where you actually put your head in to look into the viewer. It's 3D, and it can adjust. It can actually go from this position to that position. Now, I'm a very tall guy, and what I'll tell you is that I've tried every single adjustment that there is. At the end of the days that I have robots, I would tell you that the next day, my body knows that we did something, because the discomfort usually is in my neck area and my shoulders, as well as kind of lower back sometimes. The back one, we have different types of chairs that we can use for that. But in terms of ergonomics, I mean, it could be better. What would be great is if there's a way to free it up where we don't actually have to have our necks always like this in the visual cart, like kind of looking in, if something that comes to your face and you can move your face with it without, needing you to strain your neck looking in the entire time. The newer generation robots are better. I think right now we're using the XI robot. When I started, we were using S robot. S robot was, you can only change a few things. You can only change like the position of the handles. The SI was better. It gave you a little bit more room inside, and then the XI, as you saw, I wish I put the pictures of them. The XI actually has more degrees of freedom for the instruments when you're moving them. With the other robots, there was you have to clutch a lot because the space that you moved in was not as wide. Like it doesn't take very much to hit the sides of that surgeon console. So you kept clutching. What I mean by clutching is that the way this works is, if I move my hand from here to here, the machine will move, and then at some point I will hit the surgeon console, and then I have to push a clutch to reset so I can move again, so I can get more distance. So it involved a lot of clutching, and then I think the newer ones, they actually put the clutch in the fingers, so you don't actually have to use your legs to clutch. I'm kind of old school. I still use my leg to clutch on everything. So ergonomic wise, it is better, but it's okay, but it could be better. Just put it that way.
Yeah. Do you know the
wonder
cost
with all
of
these
this?
Instruments, that you wear over your face, the metaverse.
Oh, the VR. Well, that's the thing.
VRs.
I see this being merged with a VR set. It won't be 10 years. I see where it can go. And I think the thing about it is that when you use a console, the first time it's very weird, but it takes less than 20 minutes after they're kind of sitting on it, before your brain kind of remasters and said, oh, I got this. And then everything kind of starts working naturally. I see with residents all the time. They're like, I've never sat on the console before. I'm like, I know, just sit down, do some practice. And, and by the time we start a case, they can actually move things and know how to move the camera. It's like driving, initially when you're driving, you're thinking, am I driving in stick shift?
Yeah.
So like, am I in the first gear? Am I in the second gear? Okay, the sound of the car. At some point, all these things are internalized and you don't think about it anymore. You just kind of depend on your speed and the sound of the car and where you're going. You can tell what gear you're in if you need to downshift or upshift, So that's kind of like how it goes.
Does it cause a lot of eye strain?
Not eye.
Okay.
Not for me. Not eye strain. Neck strain, yes. Shoulder strain, yes. Back strain, yeah, that one I work on, like, basically, because it's all about posture. Instead of being hunched over, if you try to sit straight, the problem with that's good for your back, but then your neck goes like this, and then all of a sudden you get that pain.
Yeah. So we do have a question. Frank says, is there a cost difference between robotic versus open?
I bet there is, and I bet it's not. I haven't actually outright looked at the data, but as you can see, the robotic instrument has a lot of disposables, meaning like, we're using trocars, we're using drapes that go over the robot itself. We're using different instruments that are just a one-time use, unlike open surgery where you have a tray that you autoclave and sterilize, and you could use it a million times, and as long as it's still sharp, you keep going. Now, where if you're going to look at it just purely on the cost of operation, meaning like a robot versus open, yes, robot, in my opinion, will be. I would see it being more expensive. But if you look at it, patient experience wise, where how long does the patient stay in the hospital?
Yeah.
What are the complications the patients have? Their pain control. How quickly, did they need rehab? Did they need a lot of things? So if you look at a total care scenario, you will find out that robot is actually cheaper, because at least on my patients, on average, they're going home at day 4. Day 4 to 5, they're home. When I did open, 2 weeks, they were always in the hospital. It's more like you're waiting for their bowels to wake up. They're not passing gas. They're not ambulating. There's a lot of pain. But with robotic surgery, they're up and about the next day. There's no drains. I don't put drains. So there's no tubes coming out. The only tubes that come out are the stents from the ileal conduit. I don't put a JP drain. These things that we did when we did open surgery, that, in my opinion, they cause more pain, because think of it. If you're a patient and you got a drain sticking out of your skin, and you have an appliance for, say, the conduit, if you move around, everything will hurt. Patients are always happy. As nurses, you guys know this. Every time you pull a drain, they're so happy that came out. You pull a catheter, they're so happy that came out. So anything that would leave less drains, perfect.
We have another question. Melanie asks, approximately how long are the ureters clipped? And does there present any complication to the kidneys?
So the ureters are clipped until we do the anastomosis. So usually I would say, so drop the bladder, do the bladder part, do the lymph nodes, give it about 2 to 3 hours, and there is no long-term complication to the kidney, no.
That's good.
And it's also advantageous to us, because by the time we get to it, they're hydronephrotic and easier to sew.
Oh, never thought of that.
Yeah.
You did get a couple of good compliments. Katie says, excellent presentation. Janine, excellent presentation, and thank you. So we're getting some great compliments for you too.
Oh, thank you.
I know that, radical cystectomy for a while became, almost like not an offered procedure. And they say it's a lot of times it's because of the amount of work the urologists get involved with. I took care of all the open cases with our docs. But they said when you figure out the dollars and cents of what you get paid versus how much you have to put into that patient, it really wasn't a great financial return.
It's still a big deterrent in the sense that, like, it's a very long and complicated procedure, and it doesn't end there. You then have to then follow the patient, like they're always, like my last cystectomy, everything went well. But then she developed a urine leak, and, she had to go to IR, get a tube. Now, the great news was she went home quickly, but then, this developed later, and then we had to deal with it. Now, when I compare to my open, and that's the only reason I still do cystectomies is because compared to what it used to be with open, robotic, because it's minimally invasive and the patients do so much better. I still do it, but when you look at open cystectomy, a lot of people are not doing them anymore, and they will just rather send them to the academic institutions because for private practice urologists whose time is, very limited, going around on the same patient in the hospital for 2 weeks straight with different complications on different days is not something like they like. So, I mean, I'm not saying it doesn't happen with open. It does. With robotic, it does. But it's just way less. And then there's, we use all this ERIS protocol and ways to actually expedite patients from, prevent patients from staying in the hospital longer. And a big part of it is actually being able to complete the surgery minimally invasively. Because if you reduce pain a lot, then patients are more, when I finish a robot, the incision that, like in the female, the bladder and the lymph nodes and everything, we take it out through that vaginal opening. So there's no incisions here on their stomach. So everything is just, taken out through the vagina. In a male, I make a periumbilical incision that is kind of like very, very tiny. And from that, because the bladder, once you drain all the urine out, is, it's like a bag of balloon, but so you could pull it out from a very tiny incision. So it's the incisions are so much smaller, and the recovery is much quicker.
Yeah, good point. What's your typical follow-up then, patients who's had radical cystectomy to monitor for any recurrence?
So usually I see them like if they go home 1 week after discharge, and then again 2 weeks from that. So 1 week after discharge, then 2 weeks from that 1 week visit, and then I get a scan on everybody like around roughly 3 months, just to see what baseline, like a CT urogram, rescan everything. So I use that as my benchmark of knowing, okay, this is how we looked when after you've healed up, everything looks perfect. And then from then on, you kind of go into the NCCN guidelines of following patients that have had, cystectomy. So first, every 6 months, you're getting a scan. And then after a couple of years, you go to every year. Now, you have to remember that the same type of tumor that showed up in the bladder can still come in the renal pelvis and in the ureters. So you have to always yearly at least get imaging, like a CT urogram, just to be sure.
Doing any cytologies on the urine, looking for?
So cytologies are the way I look at it. Once the bladder is out, cytologies don't really, in my opinion, like they don't help you that much. If anything, what they do is they just make life miserable for you, in the sense that now you've hooked up the bladder to the bowel in a conduit, and the urine that comes out is always going to be, it's kind of like doing a urine culture on somebody that has a conduit. It's always going to show something crazy. And if you go chasing it down, you're never, to me, imaging and doing a lipogram or, a visual look, if there's any concerns, that's, the thing to do is just to go up there and take a look. The other thing is, with the newer tests like the CX bladders and all that, those to me are actually more useful in this scenario than just doing a good old cytology. Now, I bet there's a bunch of people that disagree, but I think in that scenario, once you remove the bladder, what you're looking for is there going to be any recurrence in the upper tract, and if if there is recurrence, you wouldn't do a nephrectomy or nephrourectomy based on its cytology. You have to do it based on actually seeing a lesion. You know what I mean?
Yeah, that makes sense. I
Can
always
you
say,
speak-
go ahead, Andrea.
Oh, I just wondering if you could speak to your enhanced recovery after surgery protocol.
So usually, like I said, one of the big things is not using drains. I try to stay away from drains as much as I can. Both my prostates, my kidneys. The only place I still put drains is partial nephrectomies, and I'm still trying to talk myself out of it. Maybe I will start doing those soon. I try to limit narcotics. So ideally, we do IV Tylenol. Now there was a time in our hospital, for some reason it was expensive. I couldn't figure that one out. IV Tylenol is great, so we alternated with IV Toradol around the clock, and we minimize narcotics as much as possible. Like I said, I don't do a bowel prep anymore, because with the bowel prep, when you wash out everything in the intestine, then you have to wait for the intestine. It goes through a phase of diarrhea. Now it wants to like constipate itself, and you're now bloated and waiting forever for it to start working. Ambulation, we get patients up the next morning. There is no two-way. There's absolutely, I don't feel like it. No, you're getting up, you're walking, we're doing this. And the other thing is like telling patients like, oh, okay, you're going to be going home in 3 days. Okay, the plan is 3 days, you're going home. Patients, when you set expectations, actually what I found is that patients actually, if you tell them like they're going to go home the next day, they know they're going home the next day, and they actually are motivated to work towards going home the next day. So you're telling them everything that they have to do in order to go home, and things like that. Now there is I'm forgetting the name. It's probably like in my preferred list. But there are other medications that we give. I tell anesthesiologists, even during surgery, I try to limit the amount of pneumoperitoneum I use. If I can drop it down as much as like sometimes I might do the surgery at 10 pneumo instead of 15. And the theory there is that when you don't distend the bowel, the abdomen as much as possible, what you end up doing is kind of maintaining some physiologic state that you don't have like air or CO2 going into sub-Q or other different places. That takes some time for that to kind of resolve and kind of delay your patients going home. So when we don't do anything super crazy, like it's more of things that we kind of think ahead of time. Is usually the pain medicine. That's the biggest Achilles heel. Trying to get everybody on board, be it your anesthesiologist, be it the hospitalist, and also be it the nurse who's on the floor who thinks patient is in severe pain and they don't have any knocks. There's no morphine ordered for this patient. Oh yeah, I don't do morphine. It's IV Tylenol, Toradol, and then I forgot to say this too. We also do blocks, a tab block. Okay. I do tab blocks now. Before tab blocks, I used to use the on-cue pain pump. I don't know if you guys know about that. It's basically it's subcutaneous lidocaine, but it's kind of mixed with, I think it's bupivacaine or whatever. They have a cocktail like that's in it basically, and it's tunnel under the skin, and over the course of 2 days, 2 to 3 days, it will slowly kind of just drip out the local pain medicine, and that usually helps with pain. But since I switched to doing tab blocks, I don't think I've seen much of a difference. Even my prostatectomy, I do it on all my patients. My prostatectomies, my kidneys, and as well as the cystectomies, and the nephrourectomies too.
That could be almost an interesting talk in its own, just post-op pain control.
I think that's a very big part of kind of like minimally invasive surgery is getting everybody on board to understand that narcotics, if you could limit it as much as possible, then recovery is much faster, much faster. And I'm telling you, like, during COVID, I was sending patients home same day. I would do a prostatectomy. I send them home same day because they got a tab block. And even now, I still wonder why I don't send them home the same day, because they spend overnight, but we're not really doing anything for them. They got a tab block, they get the surgery, they spend the night, the next morning they're up, they walk, and I'm like, we'll see you in a week in clinic to take your catheter out, and they go home.
Yeah.
So it's I think my wife is an anesthesiologist, and we always talk about this. I'm like, we kind of underutilize regional anesthetics too. We kind of go for the general in a lot of things, but using blocks. I mean, for my cases, when I do a nephrourectomy or cystectomy, they block both sides. When I do a kidney, they will block just one side. If it's a prostate, they will block usually both sides. So it works great. I mean, with tab blocks, I was sending patients home same day. Like, they wake up and they're like, I don't feel as bad as I thought I would. I'm like, and you're going home with Tylenol number 3, lots of Colace, and a lot of ambulation. That's it.
Yeah. My wife had her knee replaced, and it was outpatient. They gave her a block. She was able to walk to the car, get to the house, and the block didn't really wear off for probably a day almost.
Yeah.
And put her on Tylenol around the clock.
Yeah.
Just 500 milligrams every 4 to 6 hours. So the pain never got strong. She never took one narcotic.
Yeah.
And then you don't have the constipation issue.
You don't have the constipation issue.
You don't have, you're not like La La Land, so you're not getting up and walking and doing stuff and breathing and all the other stuff that lead to those complications. I think it's really a great thing. So let's see here. I'm going to just switch over to my other screen. That was our questions and answers. This was a great session, by the way. I really appreciated all the information that we shared today. It was fantastic. I would like to put a plug in for next week. Our own John Lynn is going to be talking about vasectomies. He's as he's mentioned on programs before, one of the largest numbers of vasectomies done in Arizona. So it's going to be interesting to hear his tricks. Yeah. But a lot of blocks used for that, and some probably distraction therapy. For those of you that are watching and want to just keep the party rolling, there is the after party. You can still go to our website. It's going to be on StreamYard this time. We're getting away from Zoom completely. So you will be able to use your mic, use your video if you want, and join us. It's up to you. It still goes on. At this point, I would like to say thanks to our great panelists here. Couldn't do it without you guys. It's been a great show and really enjoyed hearing more about robotic prostatectomy. Hope someday you might want to join us again for a discussion. Ike, it's you have a great presentation.
Anytime.
All right, great. All right, have a great day, everybody. If you're not coming to the after party, enjoy your rest of your day. Take it easy now.
All right, thank you.